Hello, I'm Dr. Russel Libby, and welcome to the World of Medicine. The show tonight is on the heart, and not the typical show on adult heart disease, although it's a pretty significant issue with close to 80 million people in our country living with heart disease, but that includes a wide spectrum. Coronary artery problems related to cholesterol, congestive heart failure, strokes, hypertension, things of that nature. But still, it is the third leading cause of death in our country, responsible for somewhere close to it is the leading cause of death, 900,000 deaths per year in our country due to heart disease and heart-related problems. Now, of course, with adults, heart disease evolves and runs a course really through a lot of the lifestyle choices and a lot of self-directed problems that people evolve through their lives. It's something that they have some degree of control over. And in that number is a very special population who doesn't have any control over what does happen to their heart. And those are babies, kids who are born with heart defects. They might be anatomic, they might be rhythm related, but whatever it may be, it's a very big issue. And that's what tonight's show is about. Somewhere close to 35,000 babies will be born with heart problems this year who will require either a medical or surgical or both kind of intervention and following for a long, long time. We've got a great audience here with us who've had that firsthand experience, and they're going to share this with you. So you get an understanding of what it's like to have a baby who does have a heart problem. Some were diagnosed very early in life, some later in life. But you're going to learn about a lot of things related to the heart and kids. Our specialist is Dr. Jim Thompson. He's a pediatric cardiologist. He's chief of cardiology, pediatric cardiology at Inova Fairfax Hospital for Children, a great institution here in Northern Virginia. And he works with Child Cardiology Associates. They have offices throughout Northern Virginia and in suburban Maryland as well. Thanks for being with us.
You're welcome.
You know, and before we get started with talking with the audience, I do want to have you just give us a little oversight on how the heart works.
Sure.
Okay?
Okay, well, I have a model here of the heart. This is the outside of the heart. There are four, I'm just going to open it up here. There are four chambers in the heart, two upper receiving chambers and two lower pumping chambers. Okay? The heart is basically a bag of muscle that pumps blood around your body. And blood circulates around your body uses up oxygen, and the blood with less oxygen in it has a bluish hue. So that blue blood comes back into the right atrium, the receiving chamber on the right side of the heart, and goes into the right ventricle, which is the pumping chamber on the right side of the heart. That chamber pumps the blood with less oxygen out to the lungs through the pulmonary artery, and the blood circulates throughout your lungs. You breathe in air, oxygen gets into the bloodstream, and that blood with oxygen turns red. The red blood with oxygen just comes back through the pulmonary veins into the left atrium, the receiving chamber on the left side of the heart. And then the left ventricle, the main pumping chamber of your heart, pumps that blood with oxygen out through the aorta and spreads it around your body to deliver the oxygen and other nutrients.
Okay, so we have a basic understanding of how the heart works. And actually, I'm going to come out and ask those of you here with a history, with kids who've had heart issues, just to briefly tell us how old they were when they were diagnosed and what the condition might have been. And we have one actually who seems to be ready and willing to tell us exactly what happened to him.
His story.
Yeah, you want to start? Well, okay, why don't you speak for him and see if we can, how old is he now?
Sasha is 8 weeks old right now.
He's 8 weeks, he's a sweetie pie, isn't he?
Thank you. And he was 4 weeks old, and we were at his 1 month pediatrician visit, and he was happy baby. We didn't notice any problems, and our pediatrician sure noticed that his heart rate was 250. So
wow.
We got to meet Dr. Thompson and Dr. Tellep very quickly. He has supraventricular tachycardia.
Supraventricular tachycardia, that's SVT,
SVT,
as they like to call it. And we're going to hear more about what happened with you guys, too. And you're here without a child today.
Correct.
But give us a little perspective. Your baby was diagnosed at what age?
He was 5 months old.
5 months old. How old is he now?
He's 4 years.
4 years.
Next week, 2 weeks.
I guess I could say at 4, it's probably just as well that he stayed home tonight.
Yeah. He'd be crying. So,
yeah. All right. Well, that's good. And his problem?
He had core triatriatum. So jump in here if I'm describing this incorrectly, but basically he had a membrane growing across his atrium, which was blocking the flow of blood, and there was leaving like a little hole to allow blood flow out of the atrium, and it was backing up into his lungs. Is that correct? And putting pressure on his lungs. So the result was he couldn't breathe deeply enough, and so he had a really fast
heart respiratory rate.
Respiratory rate, but his O2 levels looked pretty fine, and he couldn't eat because of it, so he was losing a lot of weight.
Right.
So they admitted him to the hospital.
I'm going to hear a little bit more about that, but I do want to get some history from the other folks here. And you're here with a great crew.
Hi. This is John, and John was the first one of my two kids who got diagnosed with hypertrophic cardiomyopathy about 3 years ago. Their dad died from it, and we got the results through an autopsy and started looking for it.
Wow.
And as soon as our pediatrician noticed, referred us actually to Dr. Thompson.
Right.
So we met him 3 years ago, and he,
It's
put us
been-
through the ropes of how to, deal with it and good care.
Great.
So we got, within a month of the diagnosis, we were in getting a defibrillator.
Well, we're going to hear more about that. I think that's a pretty interesting thing because it's something that actually relates to what adolescents have to fear when they're athletes and what there's a lot of confusion and controversy over. We're going to hear more about that. And I guess you can tell us, how were you when you had your experience?
I was about 3 weeks old.
3 weeks. You don't remember that well.
No.
No. But I know we have a picture of you at 3 weeks.
Yes.
Which is a pretty interesting thing to look at. And I'm not sure if Sid has the opportunity to throw that up there, but it's a pretty remarkable picture. What were your diagnoses at that time?
You can.
Mom will
my
know
mother,
better?
yes.
Okay, she can explain it. Okay.
Yeah, Katie had a coarctation of her main aortic artery, and she had her pulmonary ductus didn't close, and she had an ASD and a VSD, and she has a subaortic stenosis.
Okay.
I think I got it all.
Yeah, I think that's a pretty sophisticated set of diagnoses for sure. Well, we're going to hear more about your experience and how you've survived this incredible ordeal. And we have a few here. You are here. You have a baby who has had a problem. How old was
Yes.
your baby at diagnosis?
She was 11 days old when she
11
was
days.
diagnosed.
Wow. Very young, very quick.
Yes.
But you were already home at that point.
Yes.
Yeah.
When we went to her first well baby checkup, everything seemed to be fine, and she actually has hypothyroidism as well. And when we were at that visit for them to tell us what we needed to do for that, they discovered she has a heart murmur.
Right.
And they referred us to a pediatric cardiologist who later diagnosed her at 11 days old
And that was?
with double inlet left ventricle, which means she does not have a right ventricle, and transposition of the great arteries.
Oh, that's a tough diagnosis. We're going to hear about that too. And you have a baby.
I have two.
Two babies.
Two babies.
With heart issues.
With heart issues.
All
My
right.
first one is now 5 years old. She was diagnosed at 3 months when she was in heart failure and at the end of a PICU. And she has non-compaction of the left ventricle. And her sister, who is now 2, was diagnosed at 2 months with the same thing.
And that's a cardiomyopathy. That's a
Cardiomyopathy.
problem with the muscle of the heart.
Correct.
The way it
It's
pumps.
spongiform instead of compacting.
Okay. And you?
And me. My daughter was 2 weeks old. We were at her 2-week appointment, and she was diagnosed with a VSD, an ASD, and a PDA, which were basically holes in her heart.
Right.
She had her surgery to repair them at 2 months old, and at that surgery, they determined after that surgery that, I guess, she had complete heart block. I don't know if it was as a result of the surgery, but she now has a pacemaker. She's 100% dependent on her pacemaker.
So you went through quite a few episodes of
Yeah, we've been through a few
gasping
surgeries.
for air.
Yes.
I'm sure all of you,
Yes.
through your ordeals, had to do that as well. And your baby?
My daughter was diagnosed at 10 months old. We took her to the doctor and thought she had a cold. They sent us for a chest x-ray thinking it might be pneumonia, and her heart was big. And they diagnosed her with, it's called anomalous origin of the left coronary artery from the pulmonary artery.
Okay.
So she had to have surgery 3 days later to move her artery.
Very good. And we have a family affair up here, too. And I guess I'll ask you, since
All right.
you're the patient, right?
Yes, sir.
Well, I'm Jamie. I'm 16, and when I was 14, I was diagnosed with ventricular tachycardia, and when I went in to get the echocardiogram for that surgery, which was scheduled a week later after my diagnosis, they found out that I had an ASD as well.
So you've been through it, and as a big kid, not as a little kid.
Yeah.
So, Dr. Thompson, tell us a little bit about, I guess, the most common kinds of problems that newborns might have, that babies are born with in terms of heart defects.
Sure. Well, first of all, it's relatively common. Right. Almost 1% of all kids born have something wrong with their heart. Most of it, fortunately, is minor stuff that either doesn't need significant treatment or even goes away on its own. Small holes in the heart, things that can be dealt with pretty easily. And then a smaller percentage of those diagnosed do have bigger holes in their heart that require surgery. Some of the defects that you've heard about already, where part of the heart doesn't form properly, or the great vessels coming out of the heart. Somebody mentioned transposition, where the two blood vessels coming out of the heart are actually switched. Those are less common, but require more invasive means of repair. And then there's a fair amount of babies that have heart rhythm problems diagnosed. Fortunately, most of those go away on their own. Some need intervention or medicine throughout life. And those are the
main ones.
See.
And I know I asked you all the question before. They do such sophisticated ultrasounds on pregnant women now, looking at the babies, and they look at their brains, their kidneys, and their heart. And a lot of times they have that indication that there's something abnormal there. And none of you really had any indication beforehand. Ultrasounds are pretty much the standard of care right now prenatally. So you get a lot of referrals of babies who are detected prenatally?
Sure, we do more and more now. People, the obstetricians are becoming more educated on how to look at the heart more carefully. It used to be they just looked to see if there were 4 chambers, and they might miss a lot of the more complex defects if they weren't looking carefully. But I would say the majority of the complex defects we find out about prenatally now, as long as there's good prenatal care, of course. Right. And as opposed to when I was a fellow, we'd get calls at 4 in the morning with kids, blue babies, so to speak, coming in emergently and having to do emergent procedures. We get much less of that now. Although a lot of defects still are missed because they're very hard to diagnose. If the baby's not turned the right way and you can't get the ultrasound beams at the right angle to show them, they can be missed relatively easily.
Right. So there are some ways that people can screen, and certainly if you're pregnant or you're thinking about becoming pregnant, your obstetrician should be able to give you some good information on that. Sasha, you're too cute. I got to take advantage of you. I do. I'm sorry. You're a good baby, and it's just great to see you here. Now, he was basically a healthy pregnancy.
Yes.
You were careful and took great care of yourself, had no anticipation of anything going wrong.
Yeah, nothing. And his heart rate was, because I remember when this happened, thinking every time I was in my OB's office, and they do the heart rate, it was always, oh, there you go, buddy. It was always in the normal range. I mean, it was usually like right around 150 when they would do the heart rate, so there was never any indication. And when we took him home, he was actually a much calmer baby than our older son, who's 5. So we're like, oh, this is like our calm baby. He's like, no excitement here. Wow, were we wrong? Yeah, but there was no indication.
No. And then, so you had a pretty good month, but he just wasn't coming along. Huh?
No, well,
actually, he was fine.
He
was the one cherubic and red and pink and everything, and looking great.
No outward sign of anything.
No outward sign, but they just heard the rhythm there, and they referred you to the cardiologist, and there you went.
So I think they must have caught it pretty early, because he didn't have any because if he'd been in it for a while, apparently he would have had more difficulties. And
So he had this really fast heart rhythm. From there, you ended up going to the hospital.
Yes, we went to the emergency room, and our pediatrician got in touch with our cardiologist there and said, can someone meet them there, because he looks great when he goes in, and she was worried we were going to be stuck in the waiting room, and here he had some sort of arrhythmia, but who knows what. So we went to the emergency room. He had many an EKG lead. They tried to get him out of it with adenosine, which they thought might just break him out of it, and it didn't work. And then they put him on digoxin and adenosine together, and that still didn't work. So we came to Fairfax and Nova after that. We were over in Holy Cross in Maryland, and IV amiodarone is what broke him out of it, and he took quite a lot of it. I think they were saying that the unusual thing was that it took him a long time to break out of it, but that it's not very uncommon. So he was in the ICU for about 4 days.
Yeah.
Did he look like this the whole time?
He did.
Yes. I mean, even like he had, I remember I didn't want to have a picture of him like this, but I remember just, coming in one time and they had to, I'd left the room because the nurses had to do an IV in his scalp vein, and I was pretty sure I couldn't watch that. And I came back in and he had just, had like a bandage, everything in his head, and he was just smiling, looking. So I was like, it bothered me more than him, I think.
Yeah, at least they can see the veins up there at his age.
Yeah.
But it's like one of those, he's probably thinking to himself, I'm going to get even with you one day. I'm going to be a teenager, and you're going to pay, no question about that.
Yeah.
And it's incredible to be able to go through it that way, where he doesn't give you that sense of impending problems. And it's a pretty severe issue. Do you think his heart rate was up there for a long time prior to them discovering it?
It's unlikely that it was for a long time, because they probably would have noticed, change in color, decreased eating, breathing more rapidly. Most parents that bring kids in that have been in the SVT for a prolonged period of time, they just notice something's wrong. They're not feeding as well. They're fussy or lethargic, and it usually takes a day or so for the heart to really be affected to the extent that it'll cause those symptoms.
And are there any kind of predisposing conditions for moms that might make them more susceptible to having babies? Let's put it this way. Are there things they do during pregnancy that could contribute to this?
Not to SVT. It's just one of those things where the wiring of the heart, there's insulation, so to speak, between the upper and lower chambers.
Right.
And sometimes there's a breakdown in that insulation, so there's a short circuit, so to speak. And some kids actually outgrow it. It's almost as if when they're born, that insulation didn't grow in completely, and it does in a short period of time, whereas individuals who get diagnosed in their teenage years or later with heart rhythm abnormalities, those tend not to go away on their own and are more likely to need intervention.
So he was lucky. He got it young, and he's going to outgrow that. It's just a developmental sort of thing, and fortunately it didn't happen in a way that caused him any great harm.
That's right.
He was in the right place at the right time with good parents and good pediatrician. It all worked. And of course, it was one of those routines, just going in for your routine checkup, the follow-up, and it certainly gives credibility to pediatricians asking you to come in on that regular basis. If they're good pediatricians, they're going to pick up things like that. And they're going to hear from you, because if you were saying, even still, he hasn't been eating as much the last few days, he's been breathing faster, he doesn't seem to have the same energy, whatever, that might have happened. But going back a little bit to the prenatal issues, because I don't want to glance over those. Are there conditions that moms have during pregnancy that can affect the potential health of their heart?
Sure, there can be. I will say the majority of congenital heart defects we think don't have any major predisposing factors. It's just the embryologic development of the heart is so complex that it's almost amazing that anybody turns out with a normal heart. And if things just go a little bit one way or the other when they shouldn't, you're left with a congenital heart defect. There can be congenital infections like rubella, which is why it's important to get immunizations, particularly if you're anticipating pregnancy. Diabetes, poorly controlled diabetes, can certainly increases the incidence of congenital heart defects, and that's one of the big reasons that women who are pregnant get their glucose monitored carefully, even if you don't have diabetes. And then just good nutrition, other health issues can predispose, but for the most part, congenital heart defects are just a random occurrence.
Are there any medications that women might take that could have any impact?
Sure, there are some anti-epileptic, anti-seizure medications. Lithium is a big one, and then there are a few others, some that we probably don't know about that may influence that. There are familial patterns. There are some genetic abnormalities that can predispose children to heart defects, so that we screen for some of those, and if there's a known family history of congenital heart defects, that increases the occurrence of congenital heart defects in other relatives.
And then sort of rounding out that whole spectrum, women sometimes will get chorionic villus sampling or amniocentesis to get a genetic analysis early in the pregnancy for whatever reason that might be. And there are certain types of congenital syndromes that you might see more cardiac problems with.
Certainly, for instance, one of the more common genetic defects that we see is trisomy 21, Down syndrome. Half of all kids with Down syndrome have congenital heart defects.
So, interesting stuff, and a lot that, of course, you can do with your obstetrician to find out exactly what it's all about. I want to come back to you, because I know you had all those conditions that probably took a whole page in a textbook to even spell out. And I wanted to hear a little bit more about how your experience evolved with all this.
With Katie?
Yes.
Katie was born on her due date. She's the third of our four children. Almost 9 pounds at birth, perfect APGAR scores. Checked her out in the hospital, said she was doing great, sent us home, went for a 2-week checkup. I nursed her. They said, oh, she's doing great. She's actually back to her birth weight plus gained a 0.5 pound. What we now know is that she had fluid on board. It wasn't real weight. I kept getting a feeling that something wasn't right, and I kept calling her doctor, and they kept saying, well, it's all babies are different, or it's this, or it's that. And it was at about 3.5 weeks that we went from she's perfectly fine, her heart's good, her lungs are good, she's perfectly fine, to, oh my gosh, we're calling for air transport. They had her in the emergency room. She was actually baptized in the emergency room because they didn't expect her to survive. And they sent her up to Georgetown, and that's where we met Dr. Perry, who has since retired. And first they repaired the coarc. Right. That was the big defect. She couldn't thrive. She couldn't survive.
And the coarctation, tell us the coarctation.
Sure, the coarctation of the aorta is the big blood vessel that comes out of the heart and sends blood to the rest of the body. Right after it makes its turn to go to the lower body, there can be a narrowing called coarctation of the aorta, and that's what it is. That kind of closes off shortly after birth in people who have this condition, and it causes heart failure and a lack of blood flow to the lower body, and can put babies into a very stressful situation.
So could you tell, was she sort of blue in the lower half?
No.
No? Okay.
No, she presented no symptoms other than I just didn't have a good feeling about her. But she was dying.
You got to listen to your moms.
Absolutely.
They know what's happening. They are right on top of it. Their instincts, the people who are really close to those babies, know when something's just not right.
It wasn't right. So they repaired her coarc, and actually, in addition, her coarc, she had that, but where it's supposed to be attached to the heart, it wasn't attached to the heart at the right spot. I don't remember what that was called, but that was something else. And the arteries to her right and left arm were all knotted up inside her heart, too. I mean, she had a lot going on. So Dr. Bob Hannon was the surgeon at Georgetown that did the surgery. He did that, but Katie still couldn't thrive. She couldn't suck, swallow, and breathe. She wasn't stable. She kept failing, and her lungs collapsed. They did surgery in her room one day, just like an emergency procedure, and she just couldn't survive. So they decided to go in and take care of the ASD and the VSD, and she's got a Dacron patch for I think it's the VSD is the bottom one.
The big pumping chamber.
Yeah, basically they said she had no separation there, nothing. Right. So they took care of that, and she was in for a little over a month in Georgetown in critical care. After that, within a couple of days, it was amazing, absolutely amazing. Once they got all the repairs done, it was incredible. But at that point, she was only about 6 pounds. Yeah.
So, and she was, at that point, 5 months old? Is that what it was?
No, she was in for a month.
She was, and that was, so at what point, how old was she when she left the hospital?
She left the hospital in December. She was born in October, so she was about 2.5 months old, something like that.
And I know, Sid, we have a picture of her in the hospital. I'm not sure if we can pull that up. I'm not sure if he can hear me asking him to pull it up, but we do have a picture. And when he gets around to it, I guess we'll see it. We don't have a picture. Oh, okay. So we do have an incredible picture, I guess, at some anniversary date with lines coming out everywhere. A little baby about the size of this microphone.
That was on November 10th.
Right.
Was the day. The surgery was on the 9th. Right. And that was on the 10th, and it happened to be her great-grandmother's birthday, and it was my birthday, so the nurses at Georgetown were just amazing. They decorated her for birthday.
And took a picture.
And took a picture. They were great. Yeah. They were great nurses there.
So is that the only time you've had to be in the hospital?
Yep.
Wow.
Well, right.
No.
You didn't remember the other time. She refuses to believe she ever was back there.
I know. The only time for open heart surgery, but in December of '06, she had to have cardiovascular surgery on her left leg because her veins just suddenly got huge, and I don't know what what the term for that is. I don't remember, but it had something to do with the valves not working right in her legs and was causing a lot of pain. And she's a dancer.
So you had deep vein thromboses down there? And,
Yes, yes.
Okay. So they had to clean those up and fix that up.
Yep.
And has it been okay since then?
Yep, they're fine.
So here you go. Nutrition. I mean, was she easy to feed coming through it?
Yes.
Once she got through the surgery?
Well, she came home on NG tube feedings because she was so underweight, and they had her on Polycos and MCT oil, and she was on digoxin and aldactazide for just a couple of weeks. And once she came off of that, they took her off the Polycos and MCT oil once her weight gain started coming back, and she just
took off.
Yeah, absolutely. It was like it never happened. It literally like it never happened at all.
Amazing. And what you had there, as you know, I'm sure you know a little bit about it as you get older and you can sort of understand how the heart works. You had a pretty complicated problem there, and it's astounding, you know, as time goes on, they learn better and better techniques, but you were very fortunate to come by at a time when somebody knew what to do.
Yeah.
Because it's not that easy. And how is your life now with it all?
Completely normal. I have no medication I have to take on a regular basis. Nothing. The only thing I have to do is take medication 1 hour before I go to the dentist.
Right.
So I'm fine.
Yeah, well, you should try to stay out of the dental chair then, huh? You're pretty active. You dance,
active. Yes,
as I understand.
dance.
And that was the other picture we had that I guess we're not going to see necessarily of you performing.
Yes.
Yeah?
Yeah.
So that's great. And you're going to school now?
Yeah, I'm actually trying out for cheerleading, so I just came from cheer practice.
Oh, that's great.
Yeah.
Fantastic. So you've made a big turnaround there. That's really incredible. Really amazing. The experience that you had, give us, it wasn't quite the same as these. You were cruising along at what age now when this baby was, what, 4 months? Is that what I remember?
She was 10 months old when she was
10 months,
diagnosed.
okay.
When she was 5 weeks old, she had, what do they call it, a life-threatening event?
Oh, an ALTE, acute life-threatening event, yes. One of those where they turn blue.
She died in the grocery store, and there was a pediatric nurse actually in the grocery store. Tragic. It was the first time I ever took her out alone.
Oh boy, you were set up for that one. Oh, that's terrible.
So the woman gave her CPR in the grocery store, and we went to the hospital, and they couldn't find anything wrong with her. And we stayed overnight and sent us home. And you know, from then on, I sort of felt like
something's going to happen.
That something was going to happen.
Something had to happen. Yeah. I mean, you can't leave watching that happen and not get an explanation.
Right. And so when she was diagnosed at 10 months old, we sort of think that, I mean, I sort of think, I don't know, maybe Dr. Thompson knows for sure, that was maybe she had a major heart attack at that point, and that was what happened in the grocery store, because her condition, I guess, causes heart attacks. Is that correct? Okay. So when she was diagnosed at 10 months, strangely enough, I was relieved.
Yeah, well, you had an answer.
Right.
And through that entire period of time, did she grow and thrive?
She was perfect.
Perfect.
She was absolutely perfect.
And what happened at 10 months?
She got a really bad cold, and she was coughing and wheezing, and I mean, my husband had a really bad cold at the same time, and we took her to the doctor. And, you know, she sounded horrible. Her chest was really junky. And there's, you know, I think maybe she's got pneumonia, but it sounds really bad. And it was New Year's Eve. So they sent us to Fairfax to get a chest x-ray. It was taking forever. And like 45 minutes later, after they had the x-ray, the doctor told me, you know, her heart is large. And we don't know what's going on. But she was so healthy. They took her, they thought she had RSV, they had no idea what was going on, and then they had a technician, a sonographer, do an echo, and then who had good poker face, who said, well, you know, if it's anything serious, the cardiologist will be here, and Dr. Tubbs was there in like 20 minutes.
Right, okay.
And then he diagnosed her, and she was in heart failure. They immediately put her on intravenous Lasix. She had a lot of fluid in her lungs, and it was Dr. Ackle, who unfortunately passed away a couple of years ago, did her heart surgery, came in and spoke to us, and her heart surgery was done 3 days later, 3 or 4 days later? 3 days later.
Moved up.
Yeah.
She was in bad shape.
Yeah, she was very sick. And
so you guys went through a pretty intense ordeal. I mean, did you think everything was okay after the ALT was sent home? I mean, that 5 weeks?
Well, it was sort of waiting for the other shoe to drop to some extent. She slept on us for a month or 2 months. It was.
You were the apnea monitor.
Yeah, we had one of those, but didn't need it.
Right.
Yeah.
Okay. And, it was pretty shocking. So you had a cold, you figured I gave you a cold. And actually, it almost was potentially beneficial that she did catch your cold, because it may have been just
Perhaps,
that straw on the camel's back that allowed you to detect what needed to be detected before.
Right. I gather that a lot of times this defect is detected post-mortem.
Yeah.
It results in just a catastrophic.
And tell us a little bit about what happened there.
Sure. Well, I'll never forget the night that I got the call on Lillian. It was New Year's Eve, and I was on call, and I get a call from the resident, I think, and said, we've got a baby, the heart's big on the chest x-ray, we think it's RSV, but there's maybe something else going on, and a lot of times an x-ray gives a false positive. It's kind of like if you shine a flashlight on something, depending on where the flashlight is determines what kind of shadow it casts. Sure. It's the same thing with the heart, and I would say, 99.9% of all the patients I've seen for a big heart shown on x-ray are normal, and I always tell the parents, we're just doing this to be safe, we're doing an echo. So they call me, and I tell the resident, well, it's probably nothing, but yes, I'll come in, of course, and go in, and it took about 2 seconds to realize that it was the 0.1% that there was something going on, and I think all the cold symptoms that were bad, it wasn't really the cold causing, it was actually the heart failure. Right. And I do think that initial event that she had was related to this defect, because that's often when it's diagnosed, and then she just had because of the coronary abnormality, the coronary goes into the pulmonary artery instead of the aorta, and that's under low pressure, so it kind of acts as a pop-off, so to speak. It drains blood away from the heart rather than helping deliver blood to the heart muscle, and that just makes the heart. I couldn't do it, but it's a relatively simple fix for the heart surgeons, and she's been perfectly normal ever since.
And that's great. So that's a one-time fix.
Yeah.
And it's interesting because, of course, it's impossible to know something like that could be going on until you saw the symptoms you saw. That's a really hard one, boy. I'll tell you, being a pediatrician, I see a lot of things. That's a hard one to pick up. There are a lot of defects that occur that when you see initially, the baby does look healthy, and they're breathing a normal respiratory rate. They eat healthy, they grow well, and then they reach a critical size where all of a sudden the heart's not adequately pumping to be able to keep up with the needs, and they start to go downhill, and that can be a confusing time. I want to hear about some of what you all went through. Tell us a little bit more about the experience of just having a baby gets sick. I mean, did you have a lot of fear in the situation? Did you have, did it blow your legs out from under you?
Yeah, it completely alters your world completely, and you just reach for anything and any sort of answer, or you just reach for whatever you can hold on to figure out how to get through it, and it's not anything that you can prepare for. Right. Everybody I think here can attest to that, and and you listen to the doctors and figure it out with them, and listen to your gut, I think, a lot, and I think so many parents don't understand to listen to their gut, and so it's something that you just
have to go through.
Yeah.
And you're involved in helping parents get through these kinds of things.
Absolutely. We all of us back here are part of a group called Tender Hearts, which is a parental support group for parents and families with children with congenital heart defects. And it's a non-for-profit organization. We do lots of different events to support parents. We obviously, our main concern is supporting the parents and the families, and so we've done so many different things, like offering meals to the families to, if they have kids at home or family at home. We've run meals over to the hospital. We've gone in to visit with them. We do parental or family matching, where we'll say, okay, this family has a child with this defect, and this other family was just diagnosed with this defect. Let's pair them so that they can talk about that actual defect and what the experience was like. We also do community events. We're involved with a lot of fundraising now. I'm trying to think what other things we've done.
Sounds like a lot of good stuff.
Yeah, we do a lot of things.
How long were you in the hospital with your baby?
With my oldest, we were in for, I think, 11 days, 9 of them in the PICU.
Right. And cardiomyopathy can come with a virus or a certain type of infection, not very common as a complication of fairly common infections, to tell you the truth. And there are other types of abnormalities, and sometimes they can be genetic, and you have 2 kids with the same sort of defect, so we assume that's a pretty high likelihood.
We actually know where it is.
Yes.
It's on the first chromosome, 1p36 deletion.
And that gives you great solace in knowing where
we
it
know
is.
where it is.
Yes, absolutely.
We know where it is.
That's good. That's great.
Yeah.
And with that, you've been able to at least know what to expect. I mean, they give you a good perspective on how things go with cardiomyopathies.
Yes, we actually are. We see a doctor down here, Dr. Park down here, and we also go up to CHOP.
Right.
And they are in studies and things like that track cardiomyopathies. But right now, they always say that they're doing well, and that's what we have.
They're
There's
growing,
so
they're
much
thriving.
so much unknown, but we live in the now.
Right. Yeah. And cardiomyopathies basically are a sick heart muscle, something abnormal. What is the long-term prognosis with that kind of a problem? I mean, do they some of them end up doing well? Some of them end up.
And it depends. We're learning more and more about it all the time. As you talked about the genetic defect for non-compaction of the heart muscle. When I was a fellow, we didn't know what the defect was. I don't know if you know what year or when they discovered that. You probably know more about it than I do.
Yeah, it's very recent. In fact, the name non-compaction cardiomyopathy has happened since we got diagnosed 5 years ago.
So it's been within the last couple of years, and with the huge explosion in the knowledge base on genetic defects, we're finding that a lot of the different types of cardiomyopathies are now being paired with certain genes, which is it's helpful in diagnosis in those that aren't affected yet, and hopefully will lead to more directed therapy that will help improve the prognosis. You were asking about the prognosis. We're learning that probably one dilated cardiomyopathy is not the same as another dilated cardiomyopathy. One hypertrophic cardiomyopathy isn't the same as another, and that there will be different prognoses and different therapies depending on what these patients have. Some people could potentially have a long, healthy life with no problems. Some might need a heart transplant. Some might need medication and a defibrillator to help keep them healthy.
The outcome, generally is pretty much dictated by how sick they get through that period of time. With the cardiomyopathy, there have always been this suspicion of viruses being involved. Is that anything that people need to be aware of in terms of the types of viruses?
Well, there are a whole host of viruses that cause dilated cardiomyopathy. We think that most cardiomyopathies, particularly in older individuals, are caused by a virus, although it's very hard to prove that. Common infections cause it, and for some reason some people respond to that common infection. Parvovirus, Coxsackie virus, the virus that causes mono can cause cardiomyopathies. Millions of people get mono, but only a very small percentage of those people will have a cardiomyopathy. The younger the child who gets diagnosed with a cardiomyopathy, the more likely it is a genetic abnormality rather than an infection.
Interesting way to go. And I guess with that, you also have the potential for doing some genetic counseling once you learn a little bit about it.
That's right.
Do you send many people, let's say, do families have a higher tendency to have heart disease in newborns if they have one who already has a diagnosis?
They do. If the incidence of congenital heart defects in the general population is about 1%, slightly less than 1%. If you look at first-degree relatives, parents, siblings, and then offspring of those with congenital heart defects, the incidence goes up to about 3 to 5%, depending on what defect it is. And so there's a what we call genetic predisposition. So it's not like they're 50% likely to get a heart defect. It's, again, 3 to 5%, but more likely than the general population.
So, like all studies, which says, 3 times more likely. I mean, it looks very impressive in print, but in fact, it's still a very low incidence.
Still very low.
All right. So they just get good prenatal care, ultrasounds, some genetic testing if it's indicated, but it doesn't sound like there's much going on that way. You guys ended up in the hospital for how long?
We first went into the hospital on a Friday, and so we were there just a little over a week. They didn't find out that he had a heart defect until the following Wednesday, and they operated on Friday, and we went home on Monday. So we were in and out very quickly.
That's pretty incredible.
It is incredible.
Well, and it's fortunate the kind of defect he had wasn't something that had like major vessel type correction in terms of the surgery.
Right. It was just removal of a piece of
heart.
Yeah.
Heart. Yes.
But a piece that you didn't need. Right. That's right. It was in the way.
Always going above and beyond.
Yes. And you had a pretty difficult sequence of time. I mean, you felt there was something really going on with your baby.
We did, and my mother-in-law is actually a nurse, and when my son was born, he always breathed very rapidly. Even, when you lay a baby on you, they tend to mimic your breathing, and he never did that. He always breathed very rapidly. And my mother-in-law always said, something is wrong with this child. And we would go in, and he's fine. He's fine. Stop being that type of mother. He's fine. And it got to the point where he wouldn't go to the bathroom. And so I would call the doctor, and they would say, just give him some K-Rose syrup. He'll be fine. And so one day I went through an entire bottle of K-Rose syrup. Yes, that's a lot of sugar. And he still did not go to the bathroom. So we kept telling them something was wrong. But finally, we went in on a Friday after a interesting phone call with the doctor. And they said, let's just admit him and find out what it is. And so they did a lot of tests, and we went through a lot of bumps there, but finally we met Dr. Thompson, who helped us to
And the constipation
is totally gone. I mean, it's all because of the heart.
Right?
If you have to choose between going to the bathroom, eating, and breathing, you got to go with breathing.
Yeah,
he couldn't breathe.
You got to start there for sure.
Yes,
yep.
got to start with the breathing.
So, I won't ask if that's a common symptom of heart disease.
It's not. I think the idea was they knew something was wrong. I don't know.
They knew something was wrong.
The constipation had anything to do with it or not.
Okay, but it might have been that gallon of K-Rose syrup.
Yes, it doesn't like sugar now. I don't know why.
I would imagine. Yeah, although we can't imagine that it could predispose you to that. Now, you've been through some major procedures, right?
Mm-hmm.
Yeah. And how you feeling now?
Well, I can't do a few things, but, it's all right.
You're doing all right with it, yeah?
Yeah.
Give us a little perspective. Their dad died how long ago?
About 8.5 years ago, and through autopsy we found that he had HCM that was undiagnosed, and so we immediately started seeing Dr. Thompson in his practice, and it was just a matter of time. We knew every year when we went for the visit that this could be the year, this could be it, and both kids were being checked, and for several years it was perfectly normal, and 3 years ago John developed the thickening, physical symptoms, and within a month we were in Fairfax getting a defibrillator.
And do you remember developing those symptoms? What they were like? Do you remember anything about it?
No.
I think in all aspects he was perfectly normal. That's why I was kind of surprised. I'm like, we knew we were looking for something.
So this was on the echocardiogram?
Yes, no physical symptoms otherwise.
No physical symptoms, I see.
Internally.
Yeah. When he played soccer and baseball, and I helped coach him. And during soccer, he would come out and say he was tired, and hindsight being what it was, we were like, we could, because kids can run forever, but he would get tired pretty quickly. And at the time we didn't know anything, and then after he went in the hospital or after he got diagnosed, then it clues in. You're like, oh, why didn't I rest him some?
Yeah. Well, it wasn't your fault, I promise.
Right.
It wasn't. And he's gone through some pretty, well, I see here his shirt says labor. He's gone through something similar to it with his experience.
Yeah, we got the defibrillator implanted. 6 months later, we had a fracture in the lead that was causing inappropriate shock. So we had that repaired and the device actually replaced. And then 6 months after that, that got a fracture in it as well and caused more inappropriate shocks. And all these were device related, we guess, because the heart never showed any symptoms of needing, response from the defibrillator. And then 6 months after that, we moved it from his collarbone area to his abdomen, where it is now. And this is the longest stretch we've gone without. I think we were at 52. He's gotten 52 shocks from his defibrillator.
So your heart has stopped 52 times?
No.
Well, he wanted
the rhythm stops being normal, and it just sort of pushes it back into a normal rhythm.
No, it was just a malfunction.
Oh, the malfunction.
Yeah,
okay.
my heart
so
was
it's never
fine.
happened out of necessity.
Right. It's all been due to the, we assume.
That's shocking. Do you feel it when that happens?
Yeah.
Yeah. And what happens then?
Well,
Does it just feel weird, or?
Yeah, it just makes me jump, because I don't know when it's going to happen, so.
So it keeps you on edge.
Yeah.
They kept coming in succession, so you didn't know what was going to happen.
So you probably thought, am I being bad today? Something like that. And I understand you take medicines too.
Yeah.
And you take those on a pretty defined schedule.
Yeah.
And so you have another shocking device on your wrist that reminds you when to take it.
Yeah.
Is it helpful? You wear it all the time while you sleep too? Yeah.
It's
Good.
waterproof.
It's waterproof. Does he drool a lot? Is that the problem? No? Okay. And you also have the same diagnosis.
Yes.
And you've done pretty well with it so far, right?
Yeah.
Tell me, have you had any symptoms or anything you felt?
No, we did it purely out of curiosity and necessity, I guess, that just 3 weeks ago we found out that she has the same gene marker that John has. I'm sorry I don't know the address of the gene marker, but I have it in writing somewhere.
Okay. That's all right. Nobody knows what street it is anyway.
Yeah, but we tested John knowing that we would eventually test Peyton, and it was in the exact same spot. So otherwise she doesn't have any symptoms. It's just we know the marker is there, and they've done some precautionary things to restrict a little bit of her physical activity, but she dances and does all the normal activities. So
very neat. Good.
So she participates in a different study and different medications than John does through Boston. So again, it's two different approaches to the same diagnosis.
Right.
And Dr. Libby, if I can interject, this goes back to your earlier question about genes. A few years ago, we wouldn't have been able to identify the genetic defect that John has that caused his hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is the most common cause of sudden death in young athletes. So you read these stories in the newspaper, some guy was running around on the soccer field and dropped dead, essentially. Most likely it was hypertrophic cardiomyopathy. So knowing that John had this defect, and with his father's unfortunate history, it's almost certain that he had the same defect that his father had, that this was a genetic defect. And so he was recently tested. There are several genes identified that cause hypertrophic cardiomyopathy. His was identified, and then we tested his sister for the same genetic defect. Unfortunately, she has it, but with that testing, we hope to prevent her from developing the same degree of involvement with her heart that he has by treating it ahead of time. And so this is some of the benefit we can get, hopefully, in the future by genetic testing and identification of these problems.
And it's an interesting problem, and it's that I'd say that most parents, when they bring their kids in for their pre-participation sports physicals, have in the back of their mind, does my child have that problem that one day they're going to drop dead on the field too? And of course, listening to a heart, you usually can't pick those things up. If you have a family history, you might get an echocardiogram and then pick it up. But how common is it in the general population?
It's fortunately relatively uncommon. There are, geez, I don't know that if I'd known you would ask that question, I'd have the number off the top of my head.
That's okay.
But people have even looked at how to screen, sports participation screening, and they've done big population analyses and how you should do it. And actually, a good history And referring those patients who have a strong family history or any other risk factors is actually the best way to pick these things up. But it takes a good pediatrician and good primary care to know who to refer and who not to refer.
And I mean, I've seen some of those studies, and they say the cost-benefit doesn't justify doing it on every one. I mean, you'd have to go through several 100,000 to find one.
That's right.
Or something remarkable like that. It is something that certainly, you know, I guess if anybody has a family history with someone who has a sudden death, it's always worth looking at the heart,
Absolutely.
making sure that's not where it was. Are there any other things that people might be aware of in terms of thyroid function or anything like that that has anything to do with it?
Not with hypertrophic cardiomyopathy. There are some other rhythm abnormalities that can cause sudden death, and most of those run in families as well. They're almost all genetically linked. And so just if there's anybody in the family, you know, relatively, you know, first few generations related to that patient that have had sudden unexplained death, even if they were said, oh, he had a heart attack or Uncle Fred had this or that,
right,
and they didn't really know what happened, then other family members should get checked out. Interesting.
So it's worthwhile if you have that in the history anywhere, I guess, when you go to your pediatrician or your family practitioner for that pre-participation physical, just to make sure you mention all those kinds of things. Interesting disease, and of course, you've been through something that was interesting. It came a little bit later in life.
Later in life?
Tell me how you came to be aware and what you did.
Jamie actually had participated in soccer. She was perfectly normal baby. We never missed a well visit. Had been in at the pediatrician, perfectly healthy. And when she was 14, she had been playing soccer for a long time, and she was experiencing some racing heart issues. And I actually took her to a cardiologist, Dr. Thompson at that time, who told her that she was probably just dehydrated. And at that time, I sent her to camp at Virginia Tech with her travel soccer team. And she would call me at night and still tell me that Mom, something's wrong. My heart's racing. I feel funny. It's not right. And I knew something wasn't right. And luckily, a friend of mine sent us to an arrhythmia specialist, and Dr. Bell diagnosed her with a ventricular tachycardia. Her heart rate was over 250. 250. And she when she had a stress test, and she was barely walking. You know, not even, she wasn't even at a run. She was like walking up, like power walking. So at that point, they sent us right over to Dr. Thompson's office to have a routine echocardiogram because they were going to do an ablation for her ventricular tachycardia. And when we saw Dr. Thompson, he came in and told us that she had an ASD, which is, I guess, a hole in the heart. And then we were pretty shocked because at age 14, the pediatricians had never picked anything up. She had never
had a
symptom. She was perfectly
that's
fine.
Commonly what happens.
And
Sure.
so it was pretty shocking. And 10 days later, it was just amazing, fantastic. We didn't have to go through open heart surgery. That both of the procedures were done on one day. Mm-hmm. The ablation was done, and then Dr. Thompson did the closure of the ASD in one day, and she was back in 2 weeks playing soccer.
You must have been pretty scared.
Yeah, it was pretty overwhelming to find, both problems in the span of, I think, like 2 hours. So I didn't really know what was going on at the time, but I think it definitely turned into a positive thing overall for me. So,
yeah. So you feel good. I understand you were back on the soccer field literally a week later.
Yeah.
And wasn't there a great quote from you on that one?
Oh, geez, I don't know. Was there?
Something like, well, if you didn't play well with a weak heart, you're going to play a lot better with a strong heart.
That was the thing. Yeah, she was quite an accomplished player beforehand. And I said, well, I don't think you know how good you can be yet.
Right.
And so.
Right. And I know we have here something that you did that's pretty special. It inspired you.
It really did. I always knew that I wanted to do something in the medical field, but I wasn't really sure. And a couple weeks after my surgery, I found myself in a position where I had to pick my science fair topic. And so what I ended up doing was testing flow rates through the septal occluder, which is what they used to close my ASD. And after working such long hours on this project, it really made me realize how much that I really enjoy this, and so what I'm hoping to pursue cardiology in the future. So.
All right. So we have a future physician amongst us here. Oh, that's great. I encourage you to keep going. So it gave you that inspiration, and you actually used the material they used in your heart.
Yes, sir.
Fantastic. Pretty amazing story there. You know, we have a couple of minutes left. One of the things that we didn't cover here, which probably from a pediatric cardiology point of view is still important, is understanding a little bit about cholesterol in kids. It's always controversial as to when you test, and of course most insurance companies don't want to bother paying for it because they figure you'll be an adult when it all mounts up. But do kids get high cholesterol, and does it contribute to heart disease in the long run?
Well, they can, and as a pediatrician, I mean, the heart disease is a huge epidemic in this country, and obesity is becoming an increasingly large epidemic that I think needs to be stemmed early in life. Cholesterol is clearly an issue that's related to that. Not necessarily as big as in children. I think early it's been shown that cholesterol levels in the first few years of life do not track well with teenage and adult levels of cholesterol. So we tend not to recommend testing for young children unless there's a strong family history. If there's something called familial hypercholesterolemia, where there are very early heart attacks, very high levels of cholesterol, we would tend not to treat young children anyway. But clearly, counseling families on diet and exercise early in life and trying to develop good, healthy habits to help prevent those later changes that contribute to heart disease is very important.
Yeah, and of course, obesity or kids being overweight, we know that somewhere around 17% of kids are literally obese at the ages of 5 to 12, and that there's still an incredible percentage of kids who are really overweight and inactive, sitting in front of televisions and computer screens. And smoking is still an issue with kids, and we have to be on top of it. And I want to thank you all for being here. It's been a great show, really interesting stories that you all have. And thank you, Dr. Thompson.
You're welcome.
You did a great job telling us all we need to know. And I thank you for watching, and until the next time, I'm Dr. Russell Libby, looking out for your health. So. Now